Good afternoon, ladies and gentlemen. What I'm going to talk today is not yet. Okay. Good afternoon, ladies and gentlemen. The subject I'm going to talk this afternoon is about infection prevention with vaccine. The outline of speaking is first on the basic immunology, history of vaccination, clinical trial, vaccination in the future, and vaccine hesitancy and contraindication and adverse effect of the vaccine. You know that in order to prevent infectious disease, we can do several things. One is avoidance. We can avoid just like COVID-19. If we want to avoid this, we don't go to the public area or in the crowded area, and thus we can prevent this infection. The second one is using protective carrier, just like we wear masks, so that we won't get infection. Or sometimes we get some dirty area, we wear gloves. And the third one is personal hygiene. It means that we wash our hands frequently, for example, in COVID-19, or use a disinfectant, just like alcohol, to disinfect the environment. That's a lot of people touch it, okay? And then we can use active immunization with the vaccine that we are going to talk about this. We can use the vaccine pre-exposure to the infection. For example, we use the vaccine to prevent measles, mumps, rubella, and many others, or the Japanese encephalitis. Sometimes we give the vaccine after we expose to the virus or bacteria. For example, rabies. Afterward, bitten by the rabid dog, then we give the vaccine, just like post-exposure immunization. Or we expose to the dirty wound. Sometimes we have to give tetanus toxoid after exposure to the infection. Okay. Then the passive immunization. It means that we use the antibody from other source or from patients who recover from the infection and keep them as prophylaxis or treatment. We can use prophylaxis for prevent the infection or treat them when you get, just like we keep them after exposed to the virus, because we prevent the virus can get into the cell and neutralize the virus, or even toxin. We can give antibody for that. And once we get infected, then we have to do the other thing is, in order to reduce the complication and worsening outcome by giving antibiotics or other treatment. Now, let's review the mechanism of opponent defense, because everybody, we have the physical anatomical barrier. We have skin mucous membrane to prevent, because skin is very good protector, because the virus cannot get through the skin, many of them, except some papillomavirus, because COVID cannot get to our body through the skin. They have to go to the eye, nose, and throat, okay? And second thing is phagocytosis. In the peripheral blood, we have polymorphonuclear cell in the circulation that can kill the organism without pre-exposure before. We can, or fixed phagocytosis, in, for example, macrophage in the reticuloendothelial system, in liver and spleen. We have all of this immunity, and at birth. Also, the humoral factor, we have complement and providence system, and this system occur at birth. In the baby, never exposed to the antigen before, they also have this immunity. And children has very good innate immunity when compared with adult. Okay, for example, you see that children have, when they have COVID-19, they have very mild symptoms. Also, when they have chickenpox, they are less severe than adult, because the innate immunity is much better than adult. Okay, all of this we call innate immunity. Is mean that immunity that occur at birth without exposure to the antigen before. And the other group is humoral immunity, just like immunoglobulin, and cell-mediated immunity, and that's we call adaptive immunity. It means that you have to expose to this antigen before you can produce antibody or produce cellular immunity against that organism. Now, there's all types of vaccine. One is toxoid. Toxoid is because some disease cause the infection, some organism cause disease by toxin. For example, tetanus or diphtheria, because diphtheria cause the disease because of diphtheria toxin and tetanus toxin. So what we do is keep in toxoid, so we have antibody against toxin. If we get diphtheria toxoid and we immunize against diphtheria and tetanus, if we exposed to the diphtheria, will we get infected? Yes, we can get infection, but no disease. Once the bacteria get into our throat, they can proliferate. But once they produce the toxin, we have antibody neutralize the toxin, so we can get infection without disease. But we can spread the disease to other people. Okay. Then the second one is inactivated or Q vaccine. In the past, we use a wholesale vaccine, just like in Thailand. At the present time, we have the Sinovac. Sinovac vaccine is a Q virus vaccine. But the problem with this is that, just like in the old day, we used the herb to treat the patient. We have a lot of things. But in the present, nowadays, we try to use some ingredient that is important for the infection. For the wholesale, if you give the wholesale, the body produces antibody against neutralizing epitope and non-neutralizing epitope. And sometimes they can get problem with that. Anyway, we'll talk about this later on. And then subunit vaccine is mean that we can extract from the microorganism to get something that's important for the prevention of disease. By extraction, synthetic or DNA recombinant, for example, hepatitis B vaccine. We did not use the host virus. We use only surface antigen by using DNA technology to produce this S antigen, surface antigen. And then it's a live attenuated vaccine. It means that we try to make the virus a bacteria so that they are not virulent and they don't cause the disease, but they still have antigen produced in our immune response. And lately we have two new types of vaccine. It's a live vector, and that's in the last couple of days we have the Japanese encephalitis vaccine that we use the yellow fever vaccine as a vector and put the antigen of the Japanese encephalitis antigen envelope into that. Or dengue, we use the yellow fever too as a vector, and also then we add. And recently for the COVID vaccine, we have the, for example, vaccine from AstraZeneca, we use the adenovirus from chimpanzee as a live vector. And then we have the antigen that controls the spike protein, DNA, put into that virus. And the virus can get to the cell and produce immunity against the spike protein from the virus. And lately we have two new technology, DNA and RNA vaccine. RNA vaccine is a new one, and it's very important because it's very, you can change the antigen. We know that the spike protein, for example, for COVID-19, we know that the spike protein is the one that attached to the cell. If we have antibody against spike protein, we can immune against that infection. And then we know that RNA that's produce control the production of spike protein. So we just synthesize that RNA and make them as a vaccine. And that's, we can change this very easy. Once the virus mutate, we also can change the RNA that we use for the vaccine. Okay. And the method of administration, we have several ways to give the vaccine. One is subcutaneous injection. For the live virus, most of the live virus, we use subcutaneous injection because if we give them intramuscular, they will absorb very fast and might get anaphylactoid reaction. So we keep this vaccine into the subcutaneous tissue, so it can absorb slowly, so one get adverse reaction from that. For the antigen that have adjuvant, adjuvant in the vaccine, we have to keep them intramuscular. Otherwise, they cause a lot of reaction. We keep them deep in the muscle so that they won't cause the granular tissue of a problem from that. If we want to decrease the amount of antigen, then we use intradermal. Because the reason we use intradermal because they have a lot of Langerhans cell antigen receptor for producing. They can produce antibody better than giving sub-Q or intramuscular. But the problem, sometimes they cause a lot of reaction. If you want to get, local immunity, just like oral polio, we give them orally so that they can produce secretly IgA, protects this virus. Okay. One thing we should know about viral infection is some of them is a mucosal infection. Some of them cause systemic viral infection. The reason I mention this because now we have coronavirus infection, because rotavirus, respiratory syncytial virus, RSV, influenza, coronavirus is a superficial infection. It's all mucosal infection. When compared with those measles, mumps, rubella, polio, varicella, that's called systemic infection. The difference is the mucosal infection, there's no viremia. Systemic infection, they cause viremia. The incubation period is only for the superficial infection, it's very short, 1 to 4 days. For the systemic infection, the incubation period is much longer. Okay? And then, if the organism causes mucosal infection, antibody production is very short-lived and it's not complete when compared with the systemic infection. For example, the influenza, you give them influenza vaccine, immunity lasts for only 1 year, and you have to give them almost every year, the same as rotavirus. You get infection when you are very young. Even you are 80 years of age, you still get rotavirus infection. For measles and rubella, it's a systemic infection. It causes systemic infection. Once you get infection, the antibody is complete, it's a long life. You're immune against this infection all of your life. The reason is because the coronavirus, they get to the mucosa and within about 2 days, very short. The antibody in the body cannot come up to defend it. It takes time before they can get into the area of infection, unless your antibody is very high in the mucosa. For systemic infection, measles, incubation period is about 10 days. So the virus has to get into the blood before they can cause symptoms. When the virus gets into the blood, our antibody can neutralize it. Or say, varicella, it takes 3 weeks. So our antibody can neutralize it before they cause symptoms. But for the superficial infection, only 1 or 2 days. Antibody cannot come, to fight against this infection immediately. So the infection is not, the protection is not complete, and also it's not last very long because it's not getting to the blood. Okay? And immunity is only mucosal antibody. And the other thing is, when you use the antigen, it's a polysaccharide antigen, because, for example, Haemophilus influenza type B or pneumococcal polysaccharide antigen, they can produce antibody without help of T cell. B cell alone can produce antibody. The problem is there is no booster effect. When you give them a booster dose, you get IgM, IgA, GG, where there is no memory cell, so it never lasts very long. And children less than 2 years of age cannot respond to the polysaccharide antigen. So what we have to do is, when you want to immunize the kid with this type of antigen, we have to conjugate them with protein, a carrier protein, so it becomes the T-dependent antigen. Once it becomes T-dependent antigen, we have helper cell to help. And now we have memory cell, antibody lasts longer. And even children less than 2 years of age can respond to this type of antigen. And the other thing is important is that if the antigen is produced inside the cell, we can stimulate cytotoxic T cell, can stimulate cellular immunity. If you give the antigen from outside, exogenous pathway, we produce only antibody. This is the reason why new technology of the vaccine, they try to get virus or antigen into the cell so they can produce from inside the cell, so they can stimulate both antibody and cellular immunity. If you give them the antigen inject into the body without synthesized in our cell, then we get only antibody response. Okay. Now the antibodies against the viral infection, there's 3 types. One is irrelevant. It means that when we give them the injection, they have antibody that do nothing to the virus. But some antigen, we call it non-neutralizing antigen, and they can stimulate our body to produce antibody, but they cannot neutralize the virus. They can bind portion of virus to the cell, and that is the big problem. When we have problem with the dengue vaccine, we immunize them with dengue, vaccine. If the patient have no antibody in the past, we stimulate only one type of dengue. For example, some vaccine produce only antibodies, high antibody against dengue 2, but they have cross-reacting antibody against dengue 1, 3, and 4. The antibody against dengue 2, if you give them that one, is very high, and it lasts all of your life. But the other is cross-reacting or heterologous antigen. Antibody lasts not very long. But in the 3 or 4 years later, antibody is coming down. Then we have problem. Once we get infected with the other type of virus, antigen, the type dengue type 1 or 3, something like that, then we have non-neutralizing antibody attached virus to the cell, so the patient become severe, get severe infection because virus can get into the cell easier. Worry about COVID vaccine. We use a wholesale vaccine, inactivated vaccine. The problem is that we produce antibody against neutralizing epitope, and also we produce antibody against non-neutralizing epitope. If the virus did not change, it's okay. If we don't change that, we might get more severe infection compared with normal person. We have problem with measles in the past. Measles, we used a Q vaccine. In the beginning, we were just using measles virus, then we formalin, and then inject them 2 or 3 years later. Once they get measles, they get very severe, get a typical measles, because they have no antibody to neutralize the virus, but they have antibody to attach virus to the cell. The same thing with the dengue, and RSV, and we worry about coronavirus too. And the other epitope is neutralizing epitope. That produce antibody against the neutralizing epitope, and that prevent infection and protect our body from the infection. Because the one thing is important, to the cell, to attach to the cell first. If they cannot attach to the cell, they won't be able to cause infection. For example, HIV. If you give HIV virus in dog or cat, they cannot get infection because there's no receptor for the virus. The virus cannot get into the cell. They can infect human or the monkey because we have receptor for that HIV infection virus. The same thing it is. If we have antibody neutralize the neutralizing epitope, so the virus cannot attach to the cell, so the virus cannot cause infection. Okay. Now, then we talk about the passive and active immunity. Then in nature, we have the active immunization by infection. Once we get infection, after infection we get antibody, immunity against that. Okay. For passive, in nature, we can get that too at birth, because we have some antibodies from the mother, IgG from the mother, plus to the center, protect the baby. Okay, that's passive. That's occurred naturally. Okay, the other one is artificial immunity. We can get active by giving antigen, giving the vaccine. Okay, or we can get the passive immunity by getting antibody from people who recover from the infection, or monoclonal antibody to protect them, produced in the tissue. Give you an example that the first virus infection we have the vaccine is smallpox. It disappear from the world because we eradicate them. Smallpox. You see that the smallpox lesion is we call centrifugal. It's in the periphery, in the central part of the body. You have very few pox. Most of them is in the peripheral area, just like in the arm, in the palm. You see that the virus is in the palm. Okay. And in 1798, Edward Jenner, noticed that those who get cowpox infection, once they're exposed to the smallpox, they won't get the disease. So he noticed that if you get cowpox, you get immunity against smallpox. So they tried to do this by giving cowpox to the kid so that they won't get smallpox. And this has been used all over the world to protect smallpox. And now today we can eradicate smallpox by using this vaccine. And in the 18th century, we have smallpox vaccine. It's all of this in the early phase. We're using live attenuated vaccine, using live vaccine. We don't know how to kill the virus yet. And then in the 19th century, we have rabies vaccine. At the beginning, we used the live vaccine, but later on, we found that when we give the injection, they become more severe. But the virus can change it to become violent. And BCG in the 20th century, and yellow fever in 1915. It's also the live vaccine. Okay, and later on we have the wholesale vaccine in the 19th century. We have the flu vaccine, we have typhoid, cholera, plague, But now today we don't use it. See the infection, we can prevent infection not only by the vaccine. We can do once we know that the cause of the disease, for example, cholera, we know that it's caused by bacteria. And we know that we get this bacteria because we get contaminated food and water. And we know that the bacteria excrete in the stool, so we have, and the stool can contaminate the water that we drink, and that's called the disease. Once we know that, we can prevent the disease. Without the vaccine, we just have, good sanitation. Okay, and also we boil water and food before we eat, and we can eradicate cholera, outbreak of cholera. In the past, cholera can kill a lot of people. Without using the vaccine, we can prevent cholera. Once we know what is the cause, how we can get this disease, and we can prevent it. Okay, in the early 20th century, we have the wholesale pertussis vaccine. Influenza at the beginning, we also use a, wholesale vaccine, that's Q vaccine. Now today we don't use it. We use a subunit vaccine or the spread type of the virus from the vaccine. And diphtheria and toxoid, we use it's a purified protein produce antibody. And also after World War II, we have the many life-attenuated vaccine. We have polio vaccine, we have measles, mumps, rubella, adenovirus. Now we no longer produce that adenovirus, because in the past, the American used adenovirus inject into this soldier, but now we don't need it. And typhoid vaccine, we have the TY21A, is the live bacteria that won't cause the disease. And we have varicella vaccine, we have rotavirus, we have Japanese encephalitis, we have zoster and varicella vaccine, dengue vaccine, Zika vaccine. All of this is a life-saving vaccine, okay? And also for Q vaccine, you see that very few Q vaccine is used now today. Now we have polio, rabies, Japanese encephalitis, phase A, enterovirus 71. You see that all of these Q vaccine is a disease of nervous system and gastrointestinal system. We don't have any Q vaccine in the respiratory system. That's why when we talk about the COVID-19, when you see Sinovac, which is a Q vaccine. In the past, we never have very successful the Q vaccine in the respiratory virus. For example, measles, we cannot use that. Respiratory RSV also didn't work. And influenza wholesale worked not very well. We have to use subunit vaccine. Okay. And after World War II, now we have purified protein and polysaccharide antigen. We have pneumococcus polysaccharide, okay, meningococcus, hemophilus influenza, and now today we try to change this polysaccharide to become T-dependent antigen by conjugate with the carrier protein, for pneumococcus, meningococcus, and Haemophilus influenza. And hepatitis B, we used in the past, we use plasma. And typhoid vaccine, all these are BI antigen. It's a purified protein, okay? And a cellular pertussis vaccine. For the genetic engineer, we have the hepatitis B, the recombinant vaccine, HPV vaccine, and pertussis toxoid. Now, in order to produce a vaccine, we have to do some clinical trial. For phase 1, we have to, once we produce a vaccine, we want to test in healthy people first, okay? It may only 20% of volunteer, 20 or a little more than that, okay? And to see whether the vaccine that we produce is safe to give this to human, okay? And then whether the vaccine is immunogenic, whether when we give the vaccine to the body, whether we can produce antibody against it. And that's in the phase 1 trial. And then phase 2, when we increase the number of healthy people to 50 to 200, okay? And we have to see what formulation is good. The doses of vaccine, do we give 1 dose, 2 doses, or we give them every 2 weeks, 3 weeks, or 4 weeks? And method of administration, whether give them intramuscular, intradermal, or subcutaneous, okay? And then how are different people affected? In children, in adults, in elderly, how do they respond to this? That's phase 2 clinical trial. And then we have to check adverse effect of the vaccine. Then we have phase 3 clinical trial. Now we increase the number of healthy people to study to 100 to 10,000 people, okay? And then to check whether the vaccine is safe. Is the vaccine protective? Whether, and also we want to check, do different products of these have similar effect? And then once we get the vaccine in the market, then we have to phase 4 clinical trial. It means a post-marketing trial. We have to, because sometimes we don't see adverse effect. For example, we have Rota-Shield for rotavirus. We test 5,000 people, don't see any problem. Once we give millions of people, then we see interception, increase in interception, because the number, when we increase the number of the population, then we see the very rare side effect. If you use small number of volunteers, we don't see it. Until we increase the number, we start seeing. Just like chloramphenicol, they try 2,000 people, don't see any aplastic anemia. Once they give it to 100 or million people, you see a lot of people develop aplastic anemia from that drug. Okay, and we need them after we sell this vaccine. Then we get more data on then whether we can use for other indication, and we can compare with placebo, other trial and new schedule. As you see that in order to get a vaccine, it takes more than 10 years from purify the antigen, produce it, test in animal, and then test in human. Phase 1, phase 2, phase 3, and then try to register it. And so it takes $4 or $5 million to get this vaccine. For COVID epidemic, we have to shorten all of this. We cannot take 10 years to produce the vaccine. We try to produce this vaccine within 1 year. So we've shortened all of this. And now we have the emergency use authorization. I mean, we can give them, just primarily allow them to use the vaccine, even though we don't have a complete data, because we cannot wait for 10 years to get a vaccine. And this is a big problem, because we don't know the long-term effect and how the immunity lasts, because we give the vaccine to the people. We don't know whether the COVID vaccine we give is lasts 1 year, 2 years, 3 years. We have to wait and see, okay? And we don't know the long-term side effect of the vaccine. And we don't know whether it's really protected. So far, COVID vaccine can prevent the disease, but not infection. Once you get the vaccine, you still be able to get infection, but you have no symptom, have no disease. Okay, just like other vaccine in the past, they can prevent disease, not the infection. In the next 10 years, we look at this. We try to get vaccine against HIV So far, it's not successful. Okay, and we try to get vaccine against E. coli for the chicken for the traveler. When we go to other areas, sometimes we get traveler diarrhea. Want to get a vaccine. So far, in next 10 years, we try to do that. And in adolescent, we want to give the vaccine not only papillomavirus for the, CA of cervix. We want to get a vaccine against cytomegalovirus or herpes type 2. So far. And also we would like to get a vaccine for the nosocomial infection, because when the patient gets to the hospital, sometimes they get pseudomonas or staph infection or drug resistant. We would like to get a vaccine to protect them. And also we want to the vaccine to prevent chronic disease, just like diabetes. And we have vaccine. Even now, dengue vaccine, we have dengue vaccine, but the problem they have to give to the people who has infected with the virus before. We want the vaccine to give them to the young children who never been exposed to the virus before. Okay, and we need a malaria vaccine, many other vaccines, but a sickle vaccine, it was 71. Now, we need a cancer vaccine and COVID-19 vaccine. And the most important discovery of the vaccinology during the last 2 decades is, in the past, we used wholesale pertussis vaccine. It's caused a lot of side effects. Now we have a cellular pertussis vaccine. We have roller vaccine. We have live influenza vaccine, varicella, and SARS vaccine. We have the protein conjugated bacterial polysaccharide. It means that in the past, when you use polysaccharide vaccine, the children cannot produce antibody against it, and it really doesn't last very long. So now we have protein conjugated bacterial polysaccharide, so that the T cell can involve and produce much longer antibody. And we have genetic engineering vaccine, and now we have live adjunctive vector, and now we have combination vaccine. In the past, when children have to get 3 or 4 shots at one time, now we combine all of these in one shot, okay, a combination vaccine. And now we have also using transgenic plant as now so we have Bayer to produce COVID vaccine. Using plant produce this antigen, okay? And we have DNA vaccine and RNA vaccine. And the vaccine now today is not only for children. We can use vaccine for children, adolescents, adults, and traveler vaccine, and also elderly vaccine. In the future, we have the vaccine for all of this generation, the group of people. And as you see that recently we changed. We used to have wholesale pertussis vaccine. Now we use in DTP a cellular pertussis vaccine. In the past we used oral polio vaccine. Now we try to shift to inactivated vaccine. And in the past we separate the vaccine. We give 3 or 4 shots at one time. Now we combine all of these vaccines into one shot. And now we have in Thailand we now universal hip immunization, also universal hepatitis B vaccination. Okay, and we have new vaccine. Not available in Thailand yet, but in private practice, we already have Streptococcus pneumoniae vaccine, meningococcal vaccine. Okay, and the advantage of combination vaccine is you reduce the number of injection, and commonly better and cheaper, and you don't have to need 4 or 5 vaccines in different box. Now we put all of them in one box. Okay, and make it less complex and avoid human error. Okay, and as in a lot of people talk about this, vaccine are one of the greatest achievement of biomedical science and public health. Okay, the problem is a lot of people don't want to get a vaccine. Why? They're hesitant to get a vaccine. In the Philippines, a lot of people don't want to get a vaccine because they get dengue vaccine, and those who get the vaccine get more severe infection. Now, so they don't trust the vaccine, so they don't trust science. And now, a lot of people look at the adverse effect, look at the bad side, okay? And if there's something problem, they go to court to want to sue the doctor. And now we get information because our problem is a lot of fake news, and it's as you see that when we have disease, when we have the vaccine, just in the red color, when we give the vaccine, the number of disease going down. Once the disease going down, then people talking about side effect. Once they talk about side effect, then people stop giving the vaccine. Once they stop giving the vaccine, then they have outbreak of disease. And then, so they have to reuse the consumption of vaccine again. Finally, the infection disappear, and then we can stop giving the vaccine. Okay? And for the problem with the vaccine is that all the vaccine has some adverse effect. Okay, local reaction for sure. You give injection into the body, you have pain at the injection site, redness, swelling, and that's normal because some people say, "Well, don't worry, this vaccine has no problem," because they don't report it. If you now even the ones that said no problem, when we look at the patient who received the vaccine, many of them complain about swelling, pain, sometimes have fever, malaise because of the vaccine. You put some antigen to the body, we will have some symptom, but it's very mild, and sometimes they can get super infection. Okay, and the contraindication is one word is hypersensitivity. Then when we give the vaccine, usually we have to ask the patient wait in the clinic for 30 minutes because if they have hypersensitive or anaphylactic reaction, it usually occurs within 30 minutes, and we can give adrenaline to treat them. Okay, and they can just call febrile illness from the vaccine reaction from the antigen, and also for the pregnant woman, we try to avoid it because we worry if the mother has a baby and the baby has something wrong, they might blame the vaccine. That's why we try to not to give the vaccine to the pregnant woman until we are really sure. Then the last question is how early should we give the vaccine? We say we should give vaccine as early as possible when the patient can respond to it. But if you give 2 injections, when you give them want to get immunity very early, keep them interval very short, then you have to compromise with the immune response. For example, just like we have AstraZeneca vaccine, okay, you have to give them every 12 weeks apart. If you give them 4 weeks apart, antibody response is not very good. But sometimes we need the early immunity, so we have to shorten the interval between these two. Now we are allowed to 8 weeks instead of 12 weeks. Just like COVID vaccine, the Sinovac, you can give them 2 weeks or 4 weeks. 4 weeks is better, but we want to get immunity as early as possible, so we give them 2 weeks. Then we have to sacrifice the immunity that it might be not as good as the one we keep them as the longer interval. Okay, and I give you this picture because the one on the top, on the left side, is Dr. Takahashi is the one who produced it from Japan, who produced the varicella vaccine for chickenpox. The one on the right, Dr. Stanley Potkin, is the one who produced the rubella vaccine. And Ruth Bishop is the one who discovered rotavirus. All of these are pioneers in infectious disease and vaccine. Thank you for your attention.
Thank you for your presentation, Professor Somsak. There is a question from the participant. How could the vaccine be safety for the elderly patient who also have underlying system condition such as diabetes type 2 or hypertension?
Which vaccine?
For COVID vaccine.
Oh, COVID vaccine okay, because we know that the people who has comorbid has more serious complication and has a higher mortality rate. So you want to give this vaccine. So far, the vaccine we use has no problem with all of these people. The only problem with some vaccine we have to, in the past, healthy volunteer is very young people. They produce. Now we have to find out if you want to approve the vaccine for the COVID. We know that those who need the vaccine most is the elderly. So we have to try to give this to elderly to see whether they can respond to the vaccine. But those who has comorbid, so far there's no problem. You can keep this vaccine. to those with the hypertension or heart disease. Yes.
There is no question left.
Okay.
Thank you, Professor Somsak, for giving us the information about vaccination. Okay.